So today we'll be demonstrating the male GU exam on the mannequin or task trainer. And the exam is basically broken up into three portions: the mons and suprapubic area and inguinal area, the penis, and the scrotum. The first part of any exam is observation. We're looking for hair distribution. In the male, the hair usually comes up to the umbilicus. You're looking for the distribution of hair, the amount of hair. You're also looking for any bulges in the inguinal area. So I'll ask the patient to bear down in this position. And I usually demonstrate this by clenching my fists and bringing my arms in to give them the idea that they're clenching their abdominal muscles. I'm also looking for any asymmetry. There can be a bulge, which can be fairly subtle. And with that said, sometimes there is a symmetrical bulge. So after you've seen enough, you'll say, this looks as if both sides are bulging. You can also reinforce the exam by palpating over this area and having the patient bear down or cough. Next, we move to the penis. This model does not have a foreskin. An uncircumcised man needs to have the foreskin retracted. And when this happens, you want to have your fingers back here to keep the pubic hair away from the tip so that the pubic hair is not caught in the foreskin, or else it can be painful when you restore it. So these fingers, this is a very handy hand position to have for this exam. So these two fingers hold back the hair and the foreskin and the covering over the shaft to expose the foreskin, the glands. And then you're going to inspect the penis. You have to inspect the underside. You want to inspect the entire rim of the glands. You want to make sure that the urethra is not involved and there's no discharge. And sometimes you can feel lumps within the penis. You can also have a curvature of the penis, which should be documented. The next portion of the exam is the scrotum. This is the portion that most people have the most difficulty with. The trick again is these two fingers elevate the testicle within the scrotum. These three fingers palpate the testicle within the scrotum, making sure you cover all surfaces, including the posterior one with these fingers, feeling for any hard masses. And you're using the scrotum as a lubricated surface, and you will run into lumps or bumps. You need to apply enough pressure, but don't apply sudden pressure because that's what actually causes the pain. We're also going to palpate the spermatic cord and the vas deferens, and ordinarily the hand position would be something like this, but for the purposes of the video, I'm going to lower my hand. You'll see that I'm pushing in with my thumb, and I'm actually not retracting the penis on an actual patient. I do this again for camera clarity. I'm pinching exactly in the middle, front and back. I wouldn't do that on a real patient. And I'm drawing my fingers laterally, and I'm going to feel two structures pass through. The first is the vas deferens, which is about the diameter and texture of a pen insert, like one of the regular disposable Bic pens, a very thin but firmer tube, and then a larger, fleshier tube, which is the spermatic cord. Any tenderness with that maneuver generally implies epididymitis. The final maneuver on this portion is the invagination of the scrotum to check for hernias. I use my middle finger because it's most able to go up to this corner at the external ring. You're going to have the patient cough, and you're feeling for a tap on your finger and bear down because that takes a few seconds for the bowel to come into the scrotum if you have difficulty there. The other side is performed exactly the same way. I tend to use my left hand for the other side and the right hand for this side, but there are no hard and fast rules on that. There are two other reflexes that I'll mention at this point, which are mainly for the purposes of neurology. One is the cremasteric reflex. You're going to take a tongue depressor and stroke upward on the inside of the thigh, and you'll watch the ipsilateral testicle come up. The second is, we don't do this one very often, the bulbar cavernosus reflex, where you actually apply firm pressure just behind the glands, and that will also result in the elevation of the scrotum. And finally, the last test is the anal wink, and you take a tongue depressor. Usually you'll break it lengthwise like you're supposed to do for neurological exam, and very gently apply the corner perianally, and there is a laterality to this, so you need to be able to sense both sides, both right and left. And when you do, the anus will pucker or contract. These are all very good tests for nerves S2, 3, and 4.